Howdy folks, and you're listening to the Speak Up podcast, your number one topical discussion podcast surrounding all things mental health. Once again guys, I'm your host Ashley, and in this episode 4, I'll be talking to Zachary Kellerman, guys, who is a trained therapist with a background in mental health nursing. So he's got some psychiatric training as a mental health nurse, and he's a current therapist, and he's been involved in various different roles within mental health and also the third sector as well. So he's been involved with a social enterprise that's contracted to provide NHS support and provision for mental health in his local area, and he's currently involved in a voluntary role on the board of governors in a governance role for the board of governors for his local NHS trust, and he's worked been involved in Samaritans and also as a CQC inspector. So he comes to us with a wealth of knowledge and experience, so really grateful to have Zach on the show, really grateful. It's a long episode guys. In part 1 he talks very openly and candidly about his own personal lived experience with MDD, Major Depressive Disorder guys, which is otherwise known as treatment-resistant depression in psychiatric circles. I must stress I'm not qualified and I'm not medically qualified. A lot of this information that I state comes from a place of being well read and well researched. So I'm not personally qualified to advise. So again, disclaimer: we're not a medical podcast. Please seek the permission, the advice rather, of your GP, and don't use this as a substitute for any of that advice. So Zach talks about in part 1 his own personal lived experience of MDD, Major Depressive Disorder, treatment-resistant depression. Talks about, unfortunately, having been sectioned and put into a mental health unit at a young age, and unfortunately having difficulties with school and things. So he chronicles his own personal journey of MDD. In part 2, he talks about being the treatments being the way forward for his condition and what helps and what he believes is the way forward, guys. So that's ketamine. Ketamine, obviously, you might know that from a more illegal standpoint of it being an illegal drug. It's used in a controlled environment. It's a controlled drug. It's a tranquilizer used in animal care also, but it's being currently clinical trialled on the NHS in limited locations, and it's available privately as a nasal spray called esketamine. We're very, very dubious in the UK about having that widely available on the NHS, and it's been, as Zach says in the episode, it's been rejected various times by NICE, National Institute of Care Excellence. That's what he talks about in part 2, in the latter part rather, about ketamine being the way forward. And he states his case and talks about currently commonly prescribed antidepressants and things and antipsychotics, and about their well-known side effect profiles. And he makes his case and states that ketamine actually probably doesn't have that many drawbacks as it would seem, and talks about conservative level thinking and about how the political sphere shapes how we're prescribing drugs on the NHS, guys. And he's sort of very passionate to the point where he wants to open up a clinical hub in his region, ketamine clinical hub, for people to access this treatment, because he's obviously accessed it himself. And he talks also about transcranial magnetic stimulation, TMS, as being a last resort for him, and how he's tried that in conjunction with the ketamine to help him. So guys, hope you really enjoy listening to this episode. Really grateful to have Zach on the show. Again, disclaimer, we're not a medical podcast, and the views of the guests on the podcast don't necessarily reflect my views, although I actually am in agreement with Zach on some of the points that he makes. I think it's really good to be innovative and forward thinking in terms of the treatment and things like that, guys. So you guys take care. Hope you enjoy listening to it. I enjoyed recording it. Please like, share, comment and subscribe, guys, to our channels to share this knowledge with people. You guys take care. Hope you enjoy. Bye for now. Hello there, and welcome to another episode of the Speak Up podcast. It's episode 4, and it's another special one today because I've got a guest speaker on the show. We've got Zach here today, who is somebody with both personal experience and professional experience of mental health, having worked in the sector there professionally in many different roles in the past. So he's got a personal story and a professional story. We've got Zach here on the line right now. How are you doing, Zach?
Hi Ash, yeah, I'm absolutely fine, thank you, and thank you for having me on. How are you?
I'm very well, thanks. I'm very well indeed. So I've just sort of briefly outlined sort of your experience and things like that. But if you could tell me a little bit more about yourself and why you wanted to come on the podcast to speak up today.
So I kind of found out about the podcast through Reddit. So there's the subreddit of Mental Health UK. I saw that was a kind of an advertisement there looking for speakers, and I used to do quite a lot of public speaking back in the day. I say that like that's a very, very long time ago. It's not too long ago, but it's enough to count. And it's been a while since there's, I think, since COVID as well. There's been a lot less opportunities to do public speaking. I figured, there needs to, with the aims of the podcast as well. I mean, it's in the name, Speak Up. There's a lot that's still not talked about in the realms of mental health. I mean, the reason that I was on the kind of subreddit in the first place, not that there's a particular reason, but I've found myself often, I used to lurk a lot and to keep kind of abreast of issues around mental health in the subreddit that I mentioned, Mental Health UK. But I also found increasingly that a lot of people that post on there, they're asking not basic questions. Maybe this question's basic, but they're asking things that they should really know as a patient of a mental health service. Questions like, what can my GP do? People don't know about single point of access services, mental health. Things like that often comes up, and I think we discussed this briefly the other day, was people don't know that they can change a psychiatrist if there's a good reason for it. If you're not getting on with your psychiatrist, or if there's some conflict of interest there, a lot of people don't know that you can request that. I keep hearing from people that services are stretched, and yes, they are definitely stretched. A lot more stretched than they were, say, 10 years ago. But it doesn't take away your kind of rights as a patient. Kind of went off on a little bit of a detour there. So a bit more about myself. So I found out about the podcast through that subreddit, which I kind of lurk about, occasionally give opinions and advice. I'm in my 30s now, and I've suffered from quite severe mental health issues myself since about the age of 11. So I suffer from a severe treatment-resistant depression. Again, have done since I was 11. On top of a complex post-traumatic stress disorder. I think, before, I was a weird child, really. Before I became interested in healthcare at all as a possible career, or in general, I wanted to be a landscape gardener when I was little. I don't know many children that want to be landscape gardeners, but I wanted to be a landscape gardener.
Yeah.
But as I got older, not so much wiser, but older, definitely. Mental health kind of took over my life. It was back then. We talked about mental health even less. There's a big drive to talk about mental health in schools these days, which is good. There's still a lot more work that needs to be done, but it was never talked about then. There was no mandatory education. I mean, there's still not in a lot of schools, to be fair, from what I hear, but it was there was rumours that you'd hear about somebody suffering from bipolar or something, and that was about it. Nobody knew what bipolar was. Nobody knew what that entailed. The same with things like autism. People knew of the word, but they didn't know what was behind that. There's a huge lack of awareness, and I didn't know what was happening to me those days, and nobody else really did until CAMS eventually got involved. I stopped going to school. This is my first severe depressive episode. I must have been, there'd been times before this, so I'm talking about when I'm 15 now. There were times before this where I'd have quite regular panic attacks, really. And even, I remember the ambulance services being called out a few times. They didn't know what was happening with me. They couldn't explain it. I think out of the 3 or 4 times that they were called over the years, only one of the team that came could explain it. I think that led on. I mean, it was a long time ago, so I don't remember the exact details, but that led on to a referral through CAMS. Again, CAMS really, considering I was 15-ish, 14, 15, I might not have been the most mature person, but I certainly wasn't a child then. And I remember the way that they used to treat me was the letters that they'd send, because I wouldn't engage because I didn't know what was happening to me, and nobody would explain it. My parents didn't know, extended family didn't know. Nobody talked about it back then. CAMS came along out of nowhere. A lot of conversations behind closed doors about me, without involving me. I knew this was happening. I wasn't completely not self-aware, but I wasn't involved. And I remember one day getting a couple of letters that I didn't read, but the one that I did read was one on it. They put it all in this absolutely awful font. God, I cannot remember what the font exactly is called, but it's that really childish one that everyone hates, the really curly font in these different colours, like all the colours of the rainbow, explaining what this place called Ashville was. And Ashville was a child and adolescent psychiatric unit. It got to the point where I'd completely dropped out of school, wasn't going to school, that I was severely unwell. I would not speak to anyone at all. I wouldn't say anything. I'd be huddled at the computer, the PC that we had at home all day, and just not engage with anyone or anything. I became a complete shut-in, and eventually I got sectioned, to put a long story short, to Ashville when I was 16, 6 months, and it kind of snowballed. I don't know if that'd be the right term to use, but it kind of snowballed from there, really. I gained a lot of perspective whilst I was there. Whilst the unit itself, I was there for 8 months. Whilst the unit itself, the interventions that I had, which were practically non-existent, that wasn't helpful, but I learned a lot from the peers that were there, the young people that were there, and I learned to be a lot more reflective and introspective as well about what was happening to me. And I did learn a lot while I was there, but mostly from the other patients. And from there was, after that I was made homeless. My mum couldn't deal with when I was being discharged. Mum couldn't deal with my mental health, or the prospect of dealing with my mental health, because we all knew that I wasn't, ready to leave that unit, because I was still unwell. I was better. I was getting better, but I was still incredibly unwell. They discharged me anyway, so I was homeless for a period of time. Eventually, back then, at 16, because I was 16 then, you could actually rent on your own. I realise these days you can't. I think, and don't quote me on this, but I think you have to be 25 now to be able to claim housing benefit.
Right.
Or at least they talked about it. I haven't really fully kept up with that, but I'm pretty sure it is. You have to be 25 to claim certain benefits now. So basically, if I was in this position today, I'd be homeless. I'd still be homeless, basically, which is sad. But so I was 16, I managed to get supported in claiming benefits, and I lived on my own since. So yeah, so it's been a struggle.
Yeah.
The because I have treatment resistant severe depression. The traditional therapies, drug treatments, they haven't worked. There's been about 3 periods in my life.
So we're just talking about your diagnoses at the minute, are we? Just
yeah. So just to before I go on to kind of before I go on to what kind of, because I do easily distract myself.
That's all right.
But yeah, there was basically there was a period of so I have major depressive disorder, like I said, quite severe, and it's treatment resistant, so it doesn't respond to drug therapies or treatments. And I was put on so many over the years. I've literally got a list of about 24 different drug treatments. So yeah, there was a period of few years where I was within a community mental health team. They weren't really doing anything. They didn't know what to do with me, and I was just kind of languishing in this absolutely awful, because it was the only one I could get, this like rotten, horrible little bed to sit. Just me. I think the thing that got me on a bit of a better footing was adopting a dog. I was 17 at the time. You had to be 18 to adopt a dog. And we went to, because it was a bit of structure, basically. It's something that you can kind of grasp onto and build from. It's having that structure and that companionship. Because I didn't at the time. I lost a lot of friends from school. I didn't really keep up with many people, although dotted around all the country, should I say, from Asheville. So there's a period of a few years where, I was just languishing, and I adopted a dog. I remember going to the shelter, again 17, and saying, picked out this cute little dog called Ben. It's been a while now, so bless him, he's lived his life. But so it was me and the dog for many years.
Yeah.
I remember, I keep mentioning 17. I remember saying, "Oh, you look young. How old are you?" "Oh, I'm 17. Well, you're not supposed to. We're not supposed to let you adopt, but we can see that you care for the dog properly. So we'll just put we'll just put your 18 on the form, and we'll just sign here." So I was quite grateful for that, because having that companionship, having that sudden responsibility for something that wasn't me. And I mean, as a very depressed person, you don't really think of yourself. You neglect yourself very much. Of course. So having something else to kind of take care of, having sole responsibility of that, really helped push me out of my depression at the time. I mean, I'm not going to say it was that simple, because it wasn't. So there's been like 3 periods of my life where I've been, I'd say, well, and this was kind of the first one. So I was about 19 then, and I'd moved, because the area that I lived in, or should I say that bed sit that I lived in, it was damp, it was mouldy, it was literally falling to bits. And I was sleeping on for best part of 3 years, almost 4 years, I was sleeping on a really uncomfortable sofa bed. It did my back in. And yeah, it wasn't fit for habitation, really. I managed to get on the council list, basically, in my local area. I lived in Lincolnshire at the time. And I managed to get myself a place. And I think that combination of moving and, again, the responsibility of having the dog really kind of pushed me to go past my limits, and kept pushing me forward. And it got to a point where, I left Asheville with no GCSEs, also no qualifications. I think I had an E in mathematics, and that was it. That was seriously it. Because I was so unwell, I couldn't give a damn about education at the time.
Of course, yeah.
And I was getting towards 20, and I thought, oh, okay. And I need to be doing something with my life. I can't just coast on like this, because a lot of people say that being on benefits is all, having all that time is all, must be nice. I heard it today. I was reading a forum, and I heard it today, that not being in work must be nice. And it's not. If it's not your choice to not be in work, it is really not. And I must say that. So, and I kept getting told by the people that were close to me at the time that I don't know how he did it, and I don't know how I did it at the time. So I'd saved up a lot of money because I wasn't spending anything on myself whatsoever over those years. No reason to. Wasn't living any kind of life, so to speak. So I managed to save up enough money to purchase some A-level courses and some NVQ level 3 and 4 courses, and that's when I thought, well, what would be the point of the last? I mean, I was 19 then, so what would be the point of the last 7-8 years if I don't use that? If I don't use that experience, if I just let it go to waste, I couldn't let it go. I just could not leave up those very crucial years, some would argue, of your life alone, because it would feel like it was completely wasted. I know not everyone feels like that. I know most people don't feel like that, but I did. And I thought, I had a look around what was available, and I thought, well, why don't I train in something around mental health? And that's what kind of led me to trying to be a professional. So I caught up on my core GCSEs in maths and English very quickly, and I took on several courses, several MVQs around things like health and social care, psychology. And the main one was counselling and psychotherapy diploma. I remember doing all this work, the majority of it, should I say, the core work in about 6 months, about 3 years worth of work, and I zoomed through it completely.
So you did really well with that then.
Well, yeah. I mean, I was never. I did. So before I was sectioned into Ashford, and before I kind of stopped going to school, before I lost that interest, that zest for life, I was predicted to be like an A-star student, like one at the top in the class. I must have let a lot of teachers down, but yeah. So with that's it was a self-encouragement because there wasn't anyone else batting for my corner. I mean, the one thing that pushed me towards mental health was as a career. It wasn't just okay, let's monopolize what these bad experiences and put them into something good. It was also the awful care that I experienced back then from community mental health, especially. I mean, it got to the point where, I had qualified nurses, social workers on the team that were there to help me, and it felt like they were just there to make sure I hadn't topped myself, if I'm completely honest. There were times where I'd get a text message 20 minutes for an appointment saying I can't make it today. I'll reorganize with you, and then I would never get that text.
Sounds like a means to an end, doesn't it? A means to an end rather than...
Yeah. And I mean, that was when things were funded. Not adequately funded, but when they were a lot more funded than they were today. It got to a point where this particular professional, I won't name names, but they got investigated, essentially, because we put in complaint after complaint. She was just so unprofessional, and the way she talked to me was very belittling. It was years ago, so I don't remember exact details. I just remember the vague overview of it. But it was those kind of experiences in the CMH, and I thought I could do better than that. I could do better than people deserve better than that kind of treatment. So I qualified at level 4, diploma level in counselling psychotherapy. Back in would have been around 2018, 2019, so a while ago now. So I started off my career doing kind of light mentorship work there was a website that it was volunteer work. There was a website called like Horse's Mouth or something like that back then, where people would go to get just very generalized peer support and advice, about mental health. I remember being active on there for a while, and I remember the placement as part of my counselling psychotherapy course at the time was with a provider that and it was quite, I don't think they realised how kind of revolutionary it was at the time. And I'm just realising I said 2019, didn't I, instead of 2009. So if I skip 10 years, just ignore that. So 2009, 10. That's the time goes by very quickly. So 2009, 10, I joined a organisation that did a lot of peer support for people with personality disorders. And I remember being a counsellor there. They provided telephone and chat-based counselling interventions, mostly kind of crisis stuff. Through this organisation, this charity at the time. And I didn't stay there long. I remember there was quite a don't know how to put it really. There was quite a very uncomfortable atmosphere there at the time. And I mean, back then I would have been 20. So in terms of life experience and I was a very sheltered person, and life, considering what I'd gone through anyway, I was still a sheltered person. And I don't know. I didn't. The experiences I had there were quite poor, sadly. So I was there for about 6 months, and I decided to leave the
organisation.
The organisation as the owner, CEO at the time. It was very angry person for no reason. One of these people that just projects themselves and everything negative about them on to anyone and everyone else. So I left that organisation, and I volunteered for mine for a while, just kind of overseeing some of the support groups they had. But I eventually, to cut a long story short, very long story short, looking at the time, I used it as a springboard to join the first ever mental health nursing cohort in my area. And I remember I was the first one to be accepted onto the course. I mean, it didn't work out in the end because I'm not a psychiatric nurse anymore. No. But nursing was my passion, should I say, for a good few years. But there was a lot that went on. I mean, nursing in itself, and I must say this, and it still is like this for the work I do now. I still see it. There's a lot of bullying that goes on in nursing. It's very hierarchical. There's a lot of bullying, and it's very high pressure. I mean, our nurses, there's the strikes that have gone on, justifiably so. I'm surprised Royal College of Nursing haven't considered striking a lot sooner than this, because there was talk about it all the way, and this was about 2012, 2015. There's a lot of talk about it then, but we didn't think it would happen back then, but there was talk about it even back then. There's the hours that I was doing as a student nurse, bear in mind, was about 80 a week at points. And that was with the bursary that they used to give student nurses to live on. And I think they still give some kind of financial support, but it's not nearly as much as it used to be. And the course used to be free as well. You'd work for the NHS. The stipulation was you do 4,000 placement hours while you're a student. And the course is paid for because there's a massive shortage of nurses. I mean, you don't have that anymore.
No.
So on top of the 80 hours that nursing students will be doing a week, not always, but a lot of the time, at least half the time they're at uni, when they say a full-time course, we're not talking about 2-3 days a week of a couple of hours of lectures. It's truly full-time.
Full on, yeah.
So on top of the 80 hours that occasionally have to do, they have to take second jobs. They have to take second jobs, and they're paying for their course. I mean, the average nurse, I think, gets about £54,000-60,000 in debt by the end of their course.
Yeah.
It's why would you go into nursing these days? A lot of us back then were there because we're passionate about nursing.
Of course, yeah. And that's the right reasons to be in the job, is the passion, isn't it, and things like that. What I'll do is just want to talk a little bit about what you're currently doing at the minute, because you're involved with governance, aren't you, with an NHS trust right now?
Yeah. To cut a long story short, I left nursing. That's the second time that I had quite a severe episode, and I ended up leaving for quite a few reasons. Really, a lot of it was burnout.
Yeah.
And I retrained because I didn't use the counselling psychotherapy that I trained in, so I retrained in that. And I became most kind of recent work that I'm involved in is around governance and patient advocacy and service change. So I'm elected governor in my second term now for the Lincolnshire Partnership NHS Foundation Trust, which covers mental health services across Lincolnshire. And I also have a similar role. It's not a governor role, but it is very similar in how it works in Navigo too, who operate kind of Humberside, North East Lincolnshire services. I've been doing that again for the last 4 or so years. After COVID hit everyone hard, I think. I moved to where I am now in Grimsby. I moved just completely coincidentally. I moved at the very start, literally the same day it came to, very first day of the first lockdown. It wasn't planned like that at all. I kind of wish I'd left the move for a while, but I moved on that day. So, I was was director of services as well, third sector, so charitable services, mental health services at the time, and had been for about 3 years. Eventually, due to COVID and being especially vulnerable to a COVID infection at that time, when we didn't really know anything, we were waiting for the jabs as well. It wasn't really easy as someone who didn't drive either to travel. So on top of that, I was doing a lot of counselling as well, a lot of complex cases. What we do. I know a lot of people don't like that term. I don't particularly like the term either, but it does describe a kind of level of mental health unwellness that instead of just saying it that like that, it says it in one word. So until about last year, or about a year ago even, I was counselling as well. And the plan is to get back into that. I had plans written up to, still do have business plans written up to open up because there's nothing here, and so you have IAPT for psychological wellbeing services. You have IAPT, which is improving access to psychological therapies on the NHS, who provide mostly cognitive behavioural therapy. So most people that go there will get CBT.
Yeah.
Treatment option. You don't really get a choice. That's not the only therapy that's out there by far. And the thing about cognitive behavioural therapy, and I don't want to go too much into a tangent here, is cognitive behavioural therapy, which I am trained in, traditionally was a 12 to 18 month therapy. It was a longer term therapy. Not everyone would have to need or have 12 to 18 months. But the point is, it was a much longer term therapy, like most therapies are supposed to be. And the way that therapy is these days on the NHS anyway, is it's very much a one-size-fits-all band-aid approach. I mean, it's always been called a band-aid. It still is a band-aid. I mean, the government, not to get too political, are putting hundreds of millions into expanding IAP services, CBT, basically on the NHS, for pretty much anything and everything. It doesn't work for everyone.
No.
You know, the statistics are the national statistics, and I think this was from the Office of National Statistics to the government's own website. 49% of people that go in through the doors of an IAP service, NHS CBT, whatever you want to call it. I know it's not all CBT, but a lot of it is. 49% of people will gain benefit from IAP.
Yeah.
Which is a shockingly low number, considering that is the. I know they have the stepped up approach where you get different levels of support based on how you've engaged the service or not gained benefit from it, but it's still mostly cognitive behavioural therapy. You know, 49% of people go through those doors, don't get benefit from it. That's great, but what happens to the 51%? So where I live, there is no option. There is no other option for therapy unless you can afford to pay £50 a week to see a therapist, which is the standard kind of around here, the standard rate.
Yeah.
Now, I know about the standard rate for where I live because, you know, because of COVID, it was very difficult to get, you know, because I'm starting a new practice in a new area. When I moved here, it's very difficult to get private clients because I was in private practice as well, but mostly charitable work that I was doing. I found out about these local rates because I got a leaflet through the door, right? And it was from the charity Mind, the biggest mental health charity across the UK, advertising their counselling. I thought, oh, this is great. You know, there's not going to be as much competition if I look to set up charitable services, but there are services here for people. I turned the leaflet over, £50 a session. That's how I found out about the average rate around here. So I looked deep into it then. There's about 8 or so active therapists across this region. I mean, it's a small region, North East Lincolnshire, kind of on the side, but there's still not many compared to where I used to live in southern Lincolnshire.
Yeah.
Isn't many at all.
Yeah.
So nobody has an option around here currently that I know of anyway, and I've really looked. Not a mainstream one anyway. So where I'm heading from here after the kind of governance stuff, and I will touch back on the governance stuff, but I'll go over it quite quickly.
Yeah.
You know, the ultimate plan is to, and has been for quite a few years now, is open up a hub for alternate provision. Because I don't know anyone in my life, you know, I know people mostly from lower socioeconomic backgrounds and middle class backgrounds. Good mix there, but I don't even know people from middle class backgrounds who can afford, in this climate especially, they couldn't afford it before, cost of living crisis, but now they definitely can't. 50 quid a week for counselling. I couldn't. When I was in private practice as a therapist, I couldn't afford that, and it's kind of a prerequisite, or it's frowned upon, should I say, in some circles, not all, if you don't get therapy as a therapist, because you take on a lot of, you know,
problems,
psychological burden. It can really burn people out. I mean, I never really experienced it too much myself. There were points where I felt pressured, yes, but compared to nursing, you know, I thought it's different. It is different. I mean, as a therapist, you take on a lot more depth to people's problems. You really wrap yourself up in these people's lives, and that's not a negative thing at all. It's actually quite a privilege to be able to do that and work with them. Whilst as a nurse, it's very, you know, you often see the most severe presentations, but it's quick, fast, on to the next person. You know, you get a snapshot. You get a load of horrible snapshots of people's lives, and these tiny snapshots. While with therapy, you can. I mean, I was lucky enough anyway in positions that I've taken to be able to take time with clients to really work through their problems, and you know, it works. it doesn't work for everyone, but I'd say about 80% of the people that I saw over the 4 or 5 years that I was actively providing therapy, about 80% of people really gained quite significant benefit from it. So yeah, just going over the governance work. So I should explain that quick, because a lot of people hear the word governor. I mean, even I do these days, and I think, what the hell is this? And I still think that these on my second term, 4 years. But yeah, so governance work is very much holding. To be a governor is to hold a board of directors to account. So the people that make decisions in NHS trusts, in mental health services, you're overseeing service changes, and you're overseeing. My dog looked like he was about to be sick, so I was just kind of trying to get him out of the way before, be sick in the kitchen if you have to. That's where the tiled flooring is. I'll look after in a minute. But yeah, so governor work is it's basically it's not paid work. It's an elected role, similar to if you say on a council, you're a councilman, in that kind of way. That's an elected role by the public, and yeah, you hold the board of directors to account. It's a lot of advocacy work, like I briefly mentioned. So you'll often hear of complaints. You hear about the deaths that have happened as well occasionally, and what the mental health trust, as an example, is going to do about it, and you get to have a say in that. I'd say anyone that is very, you don't even have to be political, but especially those that are political about mental health and about wanting to improve services, really look into when your kind of governor elections are, how you can get involved, because it is very rewarding work. It's frustrating sometimes. A lot of the time it's frustrating because sometimes you don't feel listened to, but the work that you can get, you can really be involved in complete service change. And what mental health services lack, all mental health services lack, even to this day, is the patient voice. It's the personal opinion, the opinion that's formed by actual experience. So that's the kind of work I do. A lot of, like I said, patient advocacy, kind of reforming, changing services, looking towards the future, improving services. So
you've had a lot of experience, really, haven't you? And it's given you, it must have given you a unique perspective in your own practice as a therapist as well. Having, you've had the personal experience, but the professional side of it and the governance side, has that sort of shaped your practice as a therapist?
Massively. I mean, there are some things. So you're not supposed to give advice as a therapist at all, and that is a golden rule. You're not there to give advice. But I think we talked about this briefly on the phone. A lot of therapists kind of, it's not advice giving, but you can suggest things. As long as you explore it with your client, you can kind of express and suggest certain things. And I use this as an example because it was a complete turnaround. So I can't go into too much detail, but I'll go into what detail I can. I think we discussed this over the phone as well. So for anyone that listens, there's one client case that I'm particularly proud of. It's basically somebody who had been through services, very similar presentation to myself, someone that had a severe mood disorder, that was pretty treatment resistant. They'd been revolved through services for a much longer time than me. And I feel like I've been here several lifetimes. So, and they weren't getting anywhere. And we couldn't, so it was the first time this person had left the house to come to the therapy appointment. Again, this person didn't have any other option. They'd exhausted every option. They weren't getting anywhere with the consultant. They weren't getting anywhere with the CMHT. They've been like that for years, just complete stagnation. And she came to us as a last resort. And, I could really empathise with her. I feel I could empathise with her, and it's not to sound cocky or anything or arrogant. I feel I could empathise with her a lot more because I saw a lot of myself in her. I'd experienced a lot of what she went through. Now, that does have a lot of benefits, and we do need a lot more people who have been through services, being involved in services, especially on a professional level, or any level really. But it's because of that I knew kind of where to shape or where to take the therapy side of things. And, you know, as a therapist, you very much it's very much a process that you go through together. But having that initial information that was presented to me, the quote unquote case that I was given, and you know, after assessing this person, you know, I knew what it was like to be this person. I knew how horrible it was, and I knew just sitting there and talking about it might help on the day, it might help for a few days, but it's not going to help long term.
Yeah.
So eventually it came to, there was a couple of sessions where we weren't getting anywhere. You know, this person didn't, they didn't feel any better. They didn't think it was working for them. And we kind of discussed it a bit and said, give it a few more sessions, see how it goes, see how you feel. Kind of change things around a bit. I did incorporate CBT into this at that point. And, you know, CBT does have a lot of use. But the thing with the modality I use, which is mostly, it's called person-centered therapy, is you can add, or it's more eclectic, so you can pick and add certain things from the toolbox of training that you've had to add to the therapy to enhance it. Person-centered is very much a listening, passive approach, but you know, you can add things to it in more of an eclectic approach. So you take bits of some modalities, again, like CBT, like I use, to help augment what you're providing for someone. So we use a bit of CBT to see where she wanted to be. And I've been using they, but I don't think I've been carefully using they to just give it away. But yeah, it's not anything particularly confidential at that level. So I'll just go on from using she. You know, there's nothing particularly identifiable here. So yeah, she. So we use CBT to identify, kind of set some goals, and go away and write some letters to a younger self. See where she wanted to be, basically. And we're still getting nowhere. The CBT was kind of helping, but it wasn't having too much impact at that time. And it got to a point where I think we both felt frustrated. And I asked her, or we explored, you know, what has worked for you before. Has there been anything? You know, if you have a think about it, we ended the session, and that was the quote unquote homework. CBT homework was to have a think about over her life what had helped her, and there was one particular medication that did, and basically she'd been taken off this medication. She couldn't remember why. Eventually, and to put it in a roundabout way, so again, I'm very, very conscientious of how much information I should be divulging. In a roundabout way, I managed to support her in getting back on this medication. Again, this was her choice. We explored it, the pros and cons, and she wanted to go back on this medication. So I was in a fortunate enough position to explore that with her. That was half the work.
Yeah.
Just by sitting with somebody and not rushing them and listening to them. I mean, these days you get 10 minutes with your GP. They're the expert. They tell you what you should be on. You don't have a voice. Yeah. I'm sure, I know some people have great experiences with GPs, but in mine and with a lot of my clients, they have awful experiences. Same with consultants. Again, not every consultant. But there's very much, again, like I talked about hierarchy with nursing, it is very much like that across the NHS in my experience. Again, not everywhere. I'm not going to tie everyone with the same brush. But from, again, like I mentioned at the start, I came on here from Reddit, from the Mental Health UK subreddit. You know, I suggest anyone that's very interested in mental health to check it out. Some interesting conversations that happen there. You get to learn a lot as well. But, look after yourself first, because there are some things that can occasionally be quite distressing on there. Must preface that. So basically, to cut that long story short, that was half the work. She felt so much better in a period of about a month and a half. And because we weren't rushed, because this is somebody that had been failed and failed and failed by services for so many years, this was her last attempt. She said that herself, to engage with a service. I was in the privileged enough position, most clinicians aren't. And the way services are set up, they can't be. Even if they want to be, they can't be. But I was in a privileged enough position to be able to set within reason how much time, how many sessions we had. So it was an hour a week, basically. If I didn't have a client after, it would occasionally go over 10 minutes. But, in terms of therapy, I worked with her for almost a year. And after this medication change, within about a month and a half, she was a different person. Because she knew what she'd taken. She knew what worked for her. And she wasn't listened to it until me, somebody with quote-unquote authority. And in the third sector, I'd say often don't have that authority. It's a perceived authority that people have. Just for me writing a letter on her behalf, going over, with her consent, of course, going over what we talked about, what she said had helped her. And there we go. She's listened to suddenly.
Yeah.
It's disgusting, really.
So it took your voice and your letter for her to be listened to, really.
Yeah.
But it's clear, obviously, that it's given you that unique perspective and in your own approach to your own practice. I just want to move on to another question, if that's all right.
Yeah, of course.
So, just in terms of, you've stated yourself that you suffer from treatment-resistant depression. What sort of words of support would you give to somebody? And again, I use that word loosely because I'm not intended for people to advise, but if someone had to walk a mile in your shoes, what support would you say?
Clinical trials. Look for clinical trials, especially if you have treatment resistance. If several medications haven't worked for you at several doses, you are most likely treatment resistant. Now, again, this isn't advice. This is just pragmatism. Get that checked out if that's the case. A lot of, in my shoes, my experience, I kept getting put on different medication after different medication after different medication. The result of that is long-term side effects that could have been avoided. A lot of frustration, a lot of self-hatred that could have been avoided as well. And again, me being ignored because I didn't have that authority that a clinician did. So me in my professional position, I don't have that authority as a patient, even if I mention this. To services, the level of experience that I do have to try and say, look, for instance, recently I was told, we'll try and get you into psychology, you benefit from psychology. I said, well, I'm a therapist myself, an experienced therapist myself.
Yep.
I'm currently not in remission. This last episode has been the worst of my life. I think purely by the fact that I am trained in mental health and I am very self-aware and I have had years of experiencing this. It is the only reason that I'm still here today is on the day-to-day level. No matter how bad it gets, I can still somewhat rationalize with myself, somewhat pull myself out of it. And again, thanks mostly to that therapy training, that nursing training, as kind of a collation of resources. So yeah, for someone that's truly treatment resistant, that's tried so many things that doesn't feel that they have that voice, one, speak to your council of governors if you have one, and the governors are there for you. A lot of people don't know about the governors. They are there to support you. So you get staff governors that support the staff. I don't think a lot of staff know that either in trusts. So I'd say that for staff that listen to this too. If you need support, or if you need to whistleblow something, if you need to get something off your chest, you need change your support, go to your governor. That's a step that I wish more people would take with me, that I haven't experienced so much, because there's so much that we can bring up on a board level that you might not be able to get through as a single person, as that patient.
Yeah.
And again, clinical trials, if you've been on a lot of things that haven't worked for you, and I don't know if I should be advocating this really, but it's the stage that I got to, right, several years ago now, so around 2016. I'd just about been on everything, tried everything. I wasn't getting anywhere. I was getting so frustrated, and it got to a point where we paid for or my mum did at the time, bless her, paid for a private consultation with a mood disorder expert. And what happened there was, so he saw us very quickly. It cost a good few £100. I know a lot of people can't afford that. This is just what happened in my case. And, I was lucky enough that my mum could afford that for me, because I couldn't at that time. So we saw this private psychiatrist. He was part of some clinical trials for a treatment called ketamine. It's ketamine. Yep. So ketamine is it's the analgesic drug that's sometimes used as a painkiller. It is literally that. I was told that you're going to die. He was shocked that services had been so complacent. And I mean, I'm doing worse now, to be honest, on a mental health basis than I was back then. So to hear that back then, when I look back on it, I'm like, Jesus,
devastating.
What about now? I wish I had the same person now fighting my corner. But he basically said, look, we've got this clinical trial happening. So the treatment that we were going for is called transcranial magnetic stimulation. It's basically a brain stimulation, which is, in a very small nutshell, which has a similar efficacy rate, a success rate as electroconvulsive therapy, without all those horrific side effects. I mean, I've had electroconvulsive therapy. Unless you are about to die, I do not recommend it.
No.
About a third of people, I was told this isn't the official statistic, I was told this after it didn't work for me, after going through all that about 30% of people benefit from it, from the clinician that was responsible for the clinic that I went to.
Just to clarify as well, sorry. This is the NHS, isn't it?
It was a private psychiatrist we saw. It was to help us get NHS treatment. So a lot of consultant psychiatrists that you'll see privately, their day jobs in the NHS. You're not seeing anyone unless you seek out someone very specific. Like a national expert and pay for that. You're seeing somebody that works in the NHS 99% of the time. So you're not going to get a different technical
clinician.
Really, it'll just be a bit quicker. So it was on the Friday, basically, going back to that particular thing. He said, your son's going to die, to my mum, very bluntly, if you don't get immediate treatment. And he was a very compassionate person. I have all the time in the world. He's retired now, but I have all the time in the world for this person. And he said, your son's going to die. So what we're going to do is we're going to give you this transcranial magnetic stimulation treatment here, and then we'll claw back the money. So the way that works is through the NHS funding. So the way that works is usually once all the treatment options are exhausted, it will go to a kind of a panel in your local NHS. You have to justify why you're worth spending money on for treatment when treatments haven't worked for you. It's really backwards, but and it takes a long time. But he said, no, we're going to go through that. We'll give you the treatment because you need it right now. A very compassionate person. You won't get this generally. I was not expecting this either. So I got the transcranial magnetic stimulation on the Monday. So I waited the weekend, and we were down there halfway across the country, traveling there 4 times a week to get this treatment. And as a part of that, to stabilize me, so, I didn't die as his prognosis was, I was given ketamine. And this was on a clinical trial, so this was completely free. And and there are currently clinical trials happening for ketamine. There's a lot of promising research on it. And it's literally, so it was an IV ketamine, so intravenous ketamine, to again stabilize my mood. Whilst the TMS was a lot more invasive, transcranial magnetic stimulation, TMS, a lot more invasive, and it took not as invasive as ECT. Mind, it feels like you're getting a tattoo on your brain, which sounds horrific.
Yeah.
Again, it just feels weird, and you get used to it. And basically, to put that in a nutshell, they thought that both worked, but what I found was that the ketamine worked, especially that was the thing that worked. If there's anything that's ever worked for me in my position, it's ketamine. I've heard people talk about this like off switch for their mental health. You know, that they've had this treatment, it's suddenly like everything's clearer, and I've always used to think it was BS. I'm still quite skeptical about it, but I had this ketamine treatment, and after 2-3 these injections, so basically they inject it, they give it an hour to go through your system, and they flush it out. So you're really high for that hour, really high. I mean, that felt really good, to be honest. But they flush it out your system, so it's gone after the hour, and then you just get the residual effects of so you're not high anymore. And, you know, you're you. But it was like an off switch in my brain. All that noise, all that self-doubt, you know, all that difficulty with thinking, you know, being able to have cohesive thoughts. I mean, you probably hear throughout this recording that I'm a bit all over the place. And again, that's untreated severe clinical depression. It's hard to concentrate. It's hard to... I used to really love reading. That used to be my number one. I was such a nerd. I used to absolutely love reading books. I'd sit up all night, read loads of books. And I can't do that anymore. And depression's robbed me of that. I can't sit and read a book, which is... It really upsets me whenever I mention it, because it's embarrassing. It feels embarrassing. I know it's not embarrassing to the wider world, but you just can't concentrate on those words. That's how bad it gets. You can't read anything without having to reread and reread to the point you get really frustrated. The ketamine treatment, it was like I was never mentally unwell, ever. Like, I didn't know what that was.
Bit of an epiphany for you, really. Moment.
I felt, and I hate using the word normal, I felt normal. I felt normal, completely normal, like or should I say a baseline that a person, an average person without health complications should feel like.
Yeah.
I mean, it lasted because of the nature of the clinical trial, so I didn't get the top-up treatments that people would get. Now, this isn't really available on the NHS, should I say.
Yeah.
Again, there are clinical trials that are happening. So if this is something you hear of and you think that might be for me, you know, look them up. Just look up, you know, Google ketamine clinical trials UK.
It's available privately though, isn't it? But not on the NHS. So
it's available privately, mostly in London, but it costs about 15 grand.
Yeah.
Nobody can afford that so money does make the world go around, sadly.
Yeah. And this is the way forward for your condition, in your opinion, would you say?
Well, it is. This and psilocybin. So I've been fighting for a ketamine clinic up here. So there are currently 2 ketamine clinics in the UK, right? There's one in Oxford and there's one in Northampton. If you live in those areas in the NHS, you're golden. If you're someone like myself with my condition, treatment-resistant severe major depression, that's not responded to God knows how many treatments. I mean, the NICE guidelines, I believe, say 3 different combinations of treatments, but really it's a revolving door of treatments.
Yeah.
Even then, you don't really get diagnosed with it officially. You just try more and more treatments until it screws your health up completely. But that's, yeah. So if you're in my position, if you're in Oxford or Northampton, then bloody hell, go for it. Go for it tomorrow. Just push for it because it's available on your NHS. And they fought for it. Both these places absolutely fought for it. It's very innovative. I mean, but privately, yeah, about 15k, probably even more than that. It's hard to find the exact numbers on these private clinic websites because they like to be a bit coy about it. So it's about 15k then.
Yeah, because still, I always thought that ketamine, it has this kind of cloak of illegalness around it, like it's still considered an illegal drug or used in very restricted circumstances for like animal care and.
Yeah. So ketamine. So the reason that NICE, so the National Institute of Clinical Excellence, who oversee what treatments are available on the NHS, it's been put forward to the NHS so many times, it's been rejected so many times because the company Janssen & Janssen, the pharmaceutical giant, they hold the patent to S-ketamine, which is basically just ketamine in a nasal spray formulation. There's nothing else particularly amazing or different about it. It's just ketamine as a nasal spray. They put a patent on that, can charge what they want. They charge 10.5k per patient to the NHS. So this gets put to through the NICE guidelines for review as to whether the NHS can afford to fund this. They turn around and say no. Despite the NICE guidelines specifically saying there's a dire need for treatment-resistant for treatment-resistant depression. You know, depression is the number one, from what I'm remembering off the top of my head, might not be anymore, but it probably is, especially these days, number one global disease burden across the world. So, i.e., it costs economically, socially, because of in terms of livelihoods, lives, the most loss out of any illness. For 10.5k to me, it's nothing. I know to an NHS trust, they're going to think, Jesus, 10.5k for one person, that is a lot of money when we can put them on generic antidepressant A, which hasn't worked for them 5 times in a row, that costs us on generic, £6 for a pack of. But the thing is that the NHS doesn't, in my experience,
the short-sighted, aren't they?
They think of what's going to be cheapest and easiest here and now. But the thing is, they don't think of the long-term plan. In my experience, again, I must preface that. Don't want to get in trouble with work. Not that I think I would, but anyway, just in case. It tends to be, here's short treatment and cheap treatment 1. That hasn't worked. Here's short treatment and cheap treatment 2. And then it goes on and on and on. Instead of looking at more expensive, more effective treatment C, they just look at that treatment A that's cheap and effective again and again and again. And they're
going around on a merry-go-round, aren't you?
You do. You absolutely do. And I wonder how much that actually costs the NHS to continually do that. Now, so NICE guidelines basically said, no, it's 10.5k, that's too expensive. The patent that they hold, from what I read, it could easily, we could easily have generic versions of S-ketamine, so the nasal spray, as early as next year. I don't think it would be that early, personally. From people I've spoken to, it's going to be at least 10 years. So we have the option of the intravenous ketamine, literally the ketamine injections. Those cost, right, get this, for one dose, and a typical person probably get about 6 doses, maybe more, up to I think up to 12. But again, I have a very unreliable memory. Again, ECT, don't recommend it. Reason why: about 5 years of my memory is just gone from that. I know that doesn't happen to everyone, but I cannot remember long-term things anymore, which is not nice. But yeah, that aside, this would be an alternative to things like ECT and these quite archaic. I know they've modernized these archaic treatments, but they're still archaic options that we have out there. So intravenous ketamine costs £8.77 per dose, and you get about 6 doses. I know antidepressants that are prescribed very commonly, especially augmented medications. So typically with treatment resistance, which up to 30% of people will have a treatment resistance, will get augmented with a second medication. So if medication A doesn't work, you up that medication, usually twice, and it's still not working, and you've been on several other medications. Oh, let's add another medication into that. The problem there is, one, you then tripling the cost of those medications to that patient on an NHS perspective. Secondly, the patient perspective, you're tripling the side effects. long-term side effects as well.
Yeah.
And free, with some of them, like for example, risperidone, some antipsychotics, again, other antipsychotics in that class, a lot of weight gain that happens. There's already a big link between type 2 diabetes and a lot of mental health medications that are prescribed these days. I'm not here to scare anyone off, but there is evidence there that links these. It's not hard to find if you Google it.
Yeah.
So there are long-term health conditions. Things like lithium absolutely destroys your liver. On average, it can take about 20 years off somebody's life if they're on it long-term, lithium. It's one of the few medications I wouldn't be on. And another one that I want to call out is metazapine, which is very commonly prescribed these days. And the reason I call out metazapine, it is quite an effective medication, heavily sedating, and you are guaranteed weight gain. I don't care what psychiatrist or GP that don't really get any training in mental health, by the way, will say metazapine will make you gain weight because it kills the switch in your brain that tells you you're full, that tells you to stop eating. So you're going to feel hungry 24/7. And they used to use this off license or unofficially. They used to prescribe this because I've seen it. They used to prescribe this. Not always. I'm not saying there's no conspiracy here, but I'm saying it's just bad practice I've seen. They would prescribe this to people with eating disorders, so they'd gain weight.
Right. Yeah. Makes sense.
It does on a clinical level, but when you've got somebody that has severe body image issues that doesn't want to gain weight, and they're getting put on this new medication that they're most likely not going to know anything about, because I don't know anyone that gets told the full range of side effects of their medications when they're put on them. I never get told, and a lot of my clients never get told. You get someone with a severe eating disorder being put on this, they're suddenly ballooning in weight. I don't think it's them. Yeah,
and it's the medication that's doing
it. Yeah. And I use that as an example. I don't use that as, aha, gotcha. Don't take this. No, because it's sadly, metazapine is one of the more effective antidepressants, and it has one of the better side effect profiles. You're not going to be riddled with as many side effects.
Yeah.
But I think massive weight gain is not a trade-off that should be acceptable. Now, ketamine, as an example, again, for someone with treatment-resistant major depressive disorder, again, it's used increasingly for PTSD, sometimes bipolar 2, anxiety disorders too. It doesn't really have any long-term side effects.
No.
At all. There's a lot of research behind this. I'm just going to bring up my documents quick. Just looking for them. But the most severe kind of side effects you have is you might have a mild anxiety attack, because in the very rare cases, because of the nature of it.
Yeah.
Or the most common side effect, should I say, go with is, because that's a rarer side effect, is a headache, which goes away.
Yeah.
Compared to sexual dysfunction, which happens on most, if not all, SSRIs, and a lot of other psychiatric medications that are commonly prescribed, which can be permanent, by the way. Not always, but it can be permanent.
I just wanted to touch on one other point. Actually.
Sorry, I'm kind of rambling now.
Sorry.
The point with that, I'll wrap that up. The point with that is these treatments don't. There's no drawback to them. There's no. There've been several studies that have been done, because people's fear are we're putting somebody on a controlled drug. Are they going to get addicted to this? The same with psilocybin, so magic mushrooms, which is another one that works in a very similar way to ketamine. Again, there are clinical trials that are happening with that. It again works on the same areas of the brain in a nutshell. There are no drawbacks. People don't become addicted to these drugs because they're given in microdose levels, and you're not on them a long time, basically. So yeah, there's I think it's conservative level thinking that stops, like you mentioned at the start, because it's a drug.
Yeah,
I think that there's a massive reluctance there to, especially with, and I'm not going to get too political, but especially with the consecutive governments we've had, are very anti-drug. which, you know, fair enough with what's happening in the criminal underworld. But in terms of medical use, there are no drawbacks when you compare it to what we're currently prescribing. So sorry, I didn't mean to interject there. I know I've been rambling a little bit, but
that's okay. So what I was wanting to touch on was, you mentioned obviously treatment-resistant depression.
Yeah,
is the sort of pathway for that diagnosis is failure to respond to 3 or more SSRIs, isn't it?
Yeah. So they say in the NICE guidelines, they say it's free. Does that happen though? I don't think it does. It might happen in rare cases when you get a competent clinician overseeing you, but how often does that happen? Let's be honest.
Yeah.
But I would say, as a patient, a lot. I think the mental health system, and it's not any particular practitioner. I think the way the mental health system is structured is it beats you down until you feel powerless, because there are long waits. The people you see aren't always very friendly.
Yep. Yeah.
Don't always get on with them. Sometimes they are even abusive. Not always, you know. I'm not tarring everyone with the same brush. There is some genuine excellent care that I've seen out there, and I've seen a lot of it. I mean, I used to be I was a CQC inspector, Care Quality Commission, so I inspected subcontracted, not within the CQC, but as part of it.
Yeah.
As a patient expert, would inspect hospitals and NHS trusts all across the country. And there is some genuinely excellent care there. Typically tends to be the further south you live. Not always, but typically, because there's more investment. But yeah, I can't remember where I was going with that. I do apologise.
The NICE guidelines on.
Yeah, so the NICE guidelines. Yeah, will state free consecutive treatments that haven't worked. I say, if you're in that position and you feel this really applies to you, and when we talk about depression, we talk about things like incredible fatigue, forgetfulness. You've experienced it here with me, ramblings and not having like it's not a rambling, it's not having an easy cohesive thought, not an A to B to C to D to E level of thought. It's all over the place, you know, and you know, again, complete fatigue, like I said, forgetfulness, just lack of zest for life, like complete lack of zest. Your mood is flat, like it's dead in the water, and it doesn't go up or down no matter what you do. So you could do the most exciting thing in the world, you don't recognize that exciting thing in the world. I gave the example of reading. I used to love reading. Now I avoid it because I can't read, because I can't concentrate because of the depression, because of how bad it is. So when it gets that bad, and when you find yourself not able to get out of bed most days, stuff like that, that's when you got to think, and you're not responding to these treatments. Okay, this is probably me. And I say you fight for that. Everyone, it doesn't matter what your diagnosis is, you have more power than you think. It is frustrating, and you shouldn't have to be fighting for basic dignity treatment.
Yeah.
But please do.
Yeah.
Please do. Even if you feel you're seen as a problem patient, trust me, you're not. And again, that's what your governors are there for. Please go to them too. And put in complaints, because services don't, and pester them as well if you have to. That's your MP as well. Go to your MP, do whatever it takes, because at the end of the day, it's your life.
Absolutely.
Everyone deserves a good quality of life, no matter what their circumstances.
I've got 2 more questions for you. This one is one I've thrown in, so if it catches you off guard, So what would your answer be to the crisis? If I was to appoint you as Director General of the NHS, how would you fix the system?
Oh, God. Well, there's talk of parity of esteem. This talk of parity of esteem has been happening since about 2010. It's a conservative idea, like conservative government idea. If we equalise the amount of funding that physical healthcare gets to mental health, roughly, it's been a while since I've looked at these figures, but roughly mental health care gets about 8 to 10% of the funding that physical health care gets. Yet mental health, affects 1 in 4 people. So parity of esteem means you have equal funding in proportion. We don't have that. We still don't have that. What we've seen over the last 12 years, Conservative rule, is cuts to specifically mental health systems and learning disability services as well, because they're the most vulnerable and easy to cut, because we don't have, and this is why podcasts like this are such a great outlet and a needed outlet, because change doesn't happen quickly enough internally. And I do what I can in my roles to change things, and I do. I am changing things, but it's just one person. This is why a larger voice, larger platforms like this are so important. So first, we need a true parity of esteem. We need that funding. Yeah, whether that means we're taxed higher, which probably does. We need to do that. We need to pay NHS staff more.
Yeah,
we absolutely. Just do. I fully support the strikes. I know I don't want to get political, but there is a good reason for the strikes. The average nurse, I think, does not get paid what the government are saying they get paid. They're getting paid. They get started on about 23, 24K, and they go up to about creep up to 25 to 28, and they stay on that for most of their working lives. Yeah, it's not good. They got rid of all the good pensions that the NHS used to get when it's better funded. There's no, fund nurses. We need a lot more in-house training for psychiatry. I think there's like 2 schools. I mean, don't quote me on this because it's not something I've looked into. It's something I've heard about. So I could be wrong, but there's like 2 schools that specifically teach psychiatry in the UK, probably down south, might not be down south. I think there's one in Scotland. But we need to be teaching this as a speciality. We need to be reforming education around mental health. A lot of people talk about the best interventions are early interventions. That doesn't help people like me that's suffering now. And for instance, maybe people like yourself, Ash, and a lot of listeners in this podcast, but we need early intervention too. There's a lot of people that have been campaigning for child and adolescent mental health service budget increases and getting people in schools taught mental health. A lot more is being done today than it was when I was in school. It's still not enough, but we do need to focus on early intervention, but we also need to focus on the people that are living it day to day, because that's where the funding drops off. It's for people like myself, maybe people like you, Ashley, maybe people that listen to this podcast. So early intervention and people that, because the early intervention didn't work for me. I got early intervention. I'm still very ill. They're still going to get a subset of people that even with early intervention are still going to develop a serious mental health issue. And it's not a death sentence. What makes it a death sentence in this country for 99% of cases, not everyone, I think there are some people that just become way too unwell, unfortunately, but most cases, I think if the treatments were there, the modernisation of treatment was there, like the ketamine as an example, like the psilocybin as an example, we'd have people giving back a lot more to the economy. I know that's what the government loves to hear. We'd have people that weren't reliant on benefits, because nobody wants to be reliant on benefits.
No.
Nobody wants to be out of work. People want a fulfilling life, and work, a lot of people are overworked, but work is a big part of people's lives these days.
Identity,
Yeah. And so the current system's just not working. It needs reform. And I know it's happening. There's a lot of community mental health transformation that's happening across the country, but the way they're doing that is often getting a load of patients volunteering loads of hours of their time, not always, but loads of hours of their time, to tell them how they should run services. Because I've been involved in these things myself in more than one organisation, these transformation, mental health transformation things. They will take it in, but it goes in one ear and goes out the other. So we need people that have lived the experience at top positions, telling people and being listened to what should change. Again, funding, need to be paying our staff actual competitive wages, not just against the private sector, but against comparative countries. You go to Australia, a lot of my nursing cohort that I knew, a lot of them have moved to Australia, and you know why that is? Because they get paid twice as much as they do here. And you get the weather. So there's no competition at all.
A recurring theme that I'm hearing though from obviously from your answer to that is a lack of funding, a rigidness to change, and also a lack of salary for nurses and quality professionals.
And the last thing is a culture change as well. This hierarchy needs to go. There needs to be a lot more person-centered care as well. This IAP stuff, it helps people with predominantly it helps people, should I say, with low-level mental health issues. So, but 49% as a national average of how many people get benefit, and that benefit can be as low as a 1-point increase in mood and anxiety on the scales that they use. It needs to be more robust. There needs to be more options there. You need to fund therapy like we used to have, not just psychologists being able to provide long-term therapy or step free, whatever of IAPT. You need to fund counsellors and psychotherapists. We've got, I think it's 20 to 30,000 counsellors, trained counsellors in the UK, and they get trained for several years and get a few hundred hours placement experience to be able to do what they do. 20 to 30,000 that are not employed by the NHS, that are just waiting to be employed. A lot of them are forced. Therapists don't want, a lot of them, not all of them, don't want to go into private practice. They're forced into it because the NHS does not want to recognise counsellors. They don't want to have that as part of their service. Some trusts, some NHS organisations are starting to change that, but on a national level, it's not happening. So you've got 30,000 counsellors out there ready and trained, would love to work for the NHS, but there's no jobs going there unless they're trained in the IAPT model of working, which 49% of people only benefit from.
Yeah. Finally, so we'll wrap up really with the last question, which is there anything you wanted to add before we sort of finish, really?
So just a bit more about. So I did do a little bit of research. I mean, I've done a lot of research, but I picked out a few bits of my research around ketamine. And I mean, I'd urge anyone that has the power, that listens to this, to look into, even if you don't have the power, to look into the work that's going into things, alternate next generation treatments like ketamine, like psilocybin. I think there's research being done on LSD as well, and MDMA. Now, and it's not just for treatment resistance either. It's done in PTSD, and I think I mentioned before bipolar 2 as well. Occasionally bipolar 1, but I think due to the cycling nature of it, it seems a bit more risky, so it doesn't get take on as much. But it has, the thing is, the research, we're only at a relatively minute level of research for these things. Again, because they're seen as drugs, it's not, and because of the opioid crisis that we've inherited from the States, the politics behind it, there's a lot of guidance that's happening out there. And I found out this the other day through the subreddit that I mentioned, Mental Health UK. NHS England and the government, they want people off opioids. Now, I'm on opioid medication, painkillers, because I have a chronic pain condition. I'm in pain 24/7. I need this medication.
Yeah.
Right. It was so difficult to get on this medication, but the government, because of how high the statistics are, they see people getting addicted to them. They see people abusing medications, and they tie everyone with the same brush. They want everyone off these medications, and instead they're doing CBT. They're expanding CBT to include chronic conditions, chronic pain. Basically, your thinking around your chronic condition is wrong. Right. That's what it boils down to, in a very reductive way, but that's what it boils down to. So let's fix your thinking. You're always going to have that condition. There's only so much you can do to positively think yourself out of it.
Of course, yeah.
I read that they're looking to stop people being on these medications, again, which are seen as drugs, because a minute amount of people abuse them. And, there is a minute drug trade around them. Again, CBT and gardening. Now, I used to be able to do gardening as a personal aside. I used to love gardening. Again, you know where this is going if you were listening to what I was rambling about earlier, but about reading in depressive symptoms. But in regards to my physical health, since the pain got to that point, I can't do gardening anymore. So if I was prescribed that, green prescribing they call it, if I was prescribed that, it would be a slap in the face, because I'd love to be out there in my garden right now and do it up. I mean, my garden is a bit of a tip. and needs a lot of work doing to it, and I physically can't do it. So I wish I could.
Yeah.
I love gardening, but I can't do it anymore. It's another thing I can't enjoy because there's this very reductive way of looking at, and very short-term way of looking at health, especially mental health, and again, chronic health in general. So I wanted to go over ketamine very quick.
Yeah.
Because I realise I've taken a lot longer than than I was told that we might be taking.
Fine.
So I will. So I do apologise for that, and any listeners. So I want to back up what I'm saying with ketamine and psilocybin, right? So there was research. I did kind of briefly touch on this earlier, but I will kind of go into it a bit more. So there was research compiled and analysed in 2011, which is a long time ago. Makes me feel old, but it was a long time ago now. So it was a compiled, analysed research of everything that was out there. I think it was 8 studies that had been done before about the usefulness of psilocybin, magic mushrooms, in the treatment of mental health disorders, right? Because the concern is with government conservative thinking and general thinking is we don't want people addicted to new drugs that we've prescribed because we'd be responsible for that then. The research that was compiled and analysed very thoroughly in 2011 found that there was no increase in any drug abuse or addiction. Again, like I mentioned earlier, there were no to few adverse reactions, no side effects that lasted, and no long-term negative side effects when this was looked at 1 year, 2 years later. So despite the view that such drugs could potentially worsen mental health as well, it's another concern that we prescribe these psychedelics or these ones that affect the brain. This could worsen mental health. We don't want people at an increased risk of suicide or the mental health worsening, or addicted, like I said. So the repeated studies have shown that there's absolutely no increase of risk whatsoever, and this goes for both psilocybin and ketamine. In terms of overdosing, it takes 17 kilograms of magic mushrooms to overdose on them. Now, an average kind of microdose of a mushroom would be about 3 grams, maybe not even that.
Right.
So 17 kilograms. I don't know who has 17 kilograms. I don't even think mega drug barons have 17 kilograms of mushrooms.
Well, you'd have to consume a lot, wouldn't you? For
well,
that?
You'd be there. You'd have to eat nothing but for weeks. So the toxicity in taking that is, whilst there are some kind of issues, if you overdose on, say, mushrooms, if they're prescribed some medication, they're minor compared to antidepressants, for example. You'd have maybe a panic attack, a fear response. It's minuscule to the point of not really even worth mentioning more than this. So again, compared to what we currently prescribe, and 14-month follow-ups, I did kind of touch upon this, but 14-month follow-ups in one particular study, again, found no evidence of any adverse effects for patients that took on the clinical trials I'm mentioning. Much better rates of reduced suicidality, much better rates of reduced levels of anxiety, much improved mood in comparison to any cohorts, any groups that were given the placebo, so the sugar pill.
Yeah.
And the most common belief that was found throughout this particular study that I'm mentioning, that kept cropping up amongst the people that they interviewed, was that it was one of the most meaningful experiences of these people's lives to have had the chance to partake in this study to potentially improve their mental health. And then going on to ketamine very quickly, because I do appreciate that I'm taking a lot of time here, or I have taken a lot of time. I've just got to bring it up quick. I did have it here. So on top of it not costing much, I mean, in terms of the intravenous ketamine, it would be an off-license use. So the NICE guidelines I mentioned earlier, they only look at the nasal spray that costs 10.5k. Again, just to go over it again, if it was an injection per dose, it would be £8.77. And you typically get about between 6 and 12 doses. And if for someone like me, I'd probably be on a maintenance dose. So I take it monthly, once a month, probably for however long I need. Still incredibly cheap compared to even a lot of antidepressants out there. I mean, I was on off license use, the fourth most commonly prescribed medication in the States. One of the most effective ones as well, by the way, called bupropion.
Yeah, I heard of that one.
Yeah, bupropion. It costs £300. I was on this for almost a year and a half. Bupropion, off-label, off-license. What it's used for? Because it's used for smoking cessation, but it's an antidepressant. It's developed as an antidepressant. So they'll prescribe it for smoking cessation. So if you need to quit smoking, we'll give you that. They don't often give you it, but it's licensed for that. But it's not anymore, from what I understand, anyway. So please don't quote me on that. For depression in the UK, it used to be, because I had trouble getting a hold of it because of that. But on the NHS, that costs £300 a month. So I was on that for a long time. If I was on the ketamine, it cost a lot less than that. Anyway, I did kind of maybe go off on a little tangent there, which I'm guilty of. So basically, I'll go over the statistics very quickly of how many people this could potentially help.
Yeah.
Right. So just across my region alone, so North East Lincolnshire is a very small county. So we have a population of 156,900 people. So the depression rate here is 11%. So that's 17,259 people with depression in North East Lincolnshire. As a lowball figure of people with treatment-resistant depression, that's about 1,726 even. It's potentially that many people available for this, say, ketamine treatment or psilocybin treatment. I think ketamine's a lot further along as a potential treatment than psilocybin is at the minute, but psilocybin is really catching up. So the amount of people that would respond to that is as high as yeah, it is massive. It is oh god, sorry, I've got like several different tabs open and I'm just trying to find, so I've got it here. So efficacy rates, so success rates essentially of ketamine used in conjunction with an oral antidepressant is as high as 70%.
Wow, that's amazing, really.
On top of that, 68% of people that complete a course of the treatment, so again, that's about 6. For some people, that's as little as 6 of these injections, are seen as in remission. So 70% of people respond. Out of that, 68% that complete that, so again, nearly 70% will be in remission. Not just partial recovery, not just partial, just full remission. Almost 70%. And again, this isn't me saying this. This is taken from a study done in 2017, I believe, in the States.
Yeah.
So it's. Yes. We need to look at this. If you use the IV route, the injection route of ketamine, there's nothing that there's no downside compared to what we're currently treating people with. And I wish anyone that listens to this is in maybe a non-executive director needs to look into this, because we are being, as a patient cohort, when I say this, we are being severely let down. Our lives are being trapped like they're meaningless.
Yeah,
and I'd say that from the bottom of my heart. And it's not because clinicians don't care. It's because the tools that are available to them and the training that they get does not equip them to handle people that don't respond to an antidepressant or don't respond to therapy.
Absolutely, yeah. I think you're right. Well, we'll wrap it up there because we've gone on for a while. But I really appreciate the time you've taken to speak to us. It's been really, really good to hear your sort of professional and personal views. So thank you very much for taking the time to come on.
I do really appreciate the opportunity, Ash, and I look forward to tuning in, and I look forward to being a guest anytime you need me.
Yeah, excellent.
I'll try not to ramble as much if I'm on in the future.
That's absolutely fine, and you're welcome to come on whenever you want in the future. So that was Zachary Kellerman, folks. That was mental health professional, and he's got personal lived experience of treatment-resistant depression. We talked about a lot of different things there. Ketamine being the way forward for treatment of MDD, and his own personal lived experiences of mental health, folks. Just as a disclaimer as well, guys, we're not a medical podcast, although we have touched on medications and things like that and treatments available on the NHS. Always seek the medical advice of your GP first before taking up any sort of advice on the podcast on board, guys. So we're not here as a substitute for your GP's advice, guys. So thank you very much to Zachary there once again, and I hope you've enjoyed listening to episode 4. Hopefully I'll be releasing it very soon, and look forward to producing another episode with you, episode 5, next time, folks. So thank you very much, Zachary, and I'll speak to you again very soon. Thank you.
Take care.
Bye-bye now.
Hello there, folks. Thanks for listening to episode 4. That was episode 4 with Zachary Kellerman, speaking up about MDD, Major Depressive Disorder, otherwise known as treatment-resistant depression. We talked about Zachary's lived experiences of mental health within the context of MDD. He talked very candidly again about having been sectioned at a young age and placed into psychiatric care in a unit in a hospital there, and talked also about being sort of almost homeless, and also about his experiences of having taken different medications and them not really sort of helping really. And then in the latter part of the episode he talks about ketamine being the way forward, having experienced this on a NHS clinical trial. Again, just to stress, ketamine is not really widely available on the NHS. It is available privately, but on the whole it's a controlled drug, so it's only available in a limited capacity at the moment. People are trying to get it over the line, as it were, to be widely available on the NHS, but obviously it keeps getting rejected. And we talked about conservative level thinking being the sort of one of the reasons why it's not being prescribed widely. People have this sort of concern that it's going to be addictive and it's got terrible side effects. But I guess really from the podcast episode, we sort of made the point that it's no more addictive than some of the drugs that we currently already prescribe on the NHS, and there's obviously cost reasons as to why it wouldn't be put over the line on the NHS. They're very mindful of costs and things like that, understandably so. But I think generally what I got from the episode was that if and this is my opinion, if we spent more time actually prescribing, let's say for example ketamine to somebody, we'd save a lot more money in the long run, because a lot of people are spending, although they're spending small amounts on prescription medications currently, cheaper versions or whatever, or cheap alternatives, over the course of their lifetime they're probably spending just as much as it would cost you to get a treatment of ketamine. I think Zach quoted a cost, ketamine's available privately for about 10.5k, 10.4k, whatever he said, I think. So, per person, that's a lot of money to spend. So, again, there's cost concerns, things have got to be cost effective. But Zach makes his points, very, very good points, actually, and states his case that this should be widely available, and he wants to try and open up a ketamine clinic or clinical hub for ketamine in his region. I think that, generally speaking, it's very forward thinking. In my opinion, I think it's really good. We should be forward thinking and innovative, and thinking about new ways to medicate people outside of the norm and things like that. And obviously there's risks and things involved, but doing it on a micro level is a very sensible way to do that, which is what the NHS is already doing. So that's basically what he talks about in the episode, guys. It's very long, so you might benefit from pausing it and listening in segments. But guys, that was it, episode 4 with Zachary Kellerman. Hope you enjoy it, guys, as much as I enjoyed recording it. And I look forward to having you on the show again for episode 5, guys. You take care.